Hey,
All right, May 15th it is. How are you, Dr. Goldberg? You ready to rock and roll here?
I am great, Eric. I am great. Um, However, I am putting out client fires, and I don't know whether or not it was easier when I was in practice and putting them out for myself.
Sure.
Um, you know, I you know what my problem is? I care too much, and you can't shut that off. So here's I want your opinion about how you deal with this. So I have a client who's transitioned their practice. Another doctor's come in and the doctor is
Dr. One or
asking
Dr. Two?
Dr. So the there was a seller and a buyer.
Okay.
So Dr. Buyer comes into the practice and starts doing some things that the staff don't feel comfortable with. So the staff now goes to Dr. Seller,
Who's
and
still an associate?
who is actually not an associate. So they're they're going to move out of the practice eventually. They've separated their specialty from the general, and they're going to go move their specialty practice into another location.
Yeah.
But
Got it.
until that location's ready, they have the option of staying there for 6 months.
Okay.
So turns out that Dr. Buyer asked the front desk to backdate an insurance form.
Backdate it. Backdate it. Okay.
So patient A comes in, has a procedure done, and then tells the doctor or the staff,
Oh, I lost my
my
insurance.
insurance, my insurance lapsed last month. Could you date it to April 30th? One
Hmm.
scenario. And I have to tell you, I've had that, I've had patients
Yeah.
ask that of me.
And you have to, right there is the moment where Dr. Byer has to have the conversation and explain why you can't do that. Yeah.
And it turns out that Dr. Buyer has a different definition of what a core buildup is. Dr. Buyer thinks that a core buildup isn't just putting stuff on the tooth to build up the core.
Mm-hmm.
It's you can say it's a core buildup if there's additional material that has to be put into the crown itself.
Oh.
So in essence, Dr. Buyer is charging for things that are not being done.
Hmm.
Mm.
Yikes. Usually, I got the other problem where they're doing buildups and not even charging for it.
Yeah. So, so I always, it goes back to our something is it's sort of many of our conversations come back to this same philosophy is trying to figure out why something like that happens, right? Why does a doctor do stuff? Why does staff do things like that? Why does
Hmm.
doctors do stuff like that? And I think it comes down to a focus on production as opposed to a focus on patients.
Hmm.
So who was it that said, was it Drucker? says, whatever you measure, you get more of. So, something to that effect, right? Um, one of my, and I think we've probably talked about this, one of my pet peeves about morning huddle being about production.
Hmm.
So is it about production, or is it about patient care?
Hmm.
Where's your focus? So, I think today it's difficult. And we've had how many of your clients have tried to offload some low paying PPOs?
Yeah, it's number one topic right now.
Right. So there's a switch from wanting wanting to be in network or accepting insurance as a way to compete, and what that really means. And I've had the experience hiring associates who had worked in insurance driven practices where they practiced insurance.
Hmm.
They didn't practice dentistry. So, and practicing insurance gets you habitualized into certain things. Like, okay, we're only going to present what the insurance is going to cover, because if I present something that the insurance is not going to cover, since you, patient, are insurance driven, I'm just not going to present something where I'm going to get a no.
Yeah.
No one likes being told no.
Approval addiction. That's just a dentist who is insurance driven.
Not just. Oh,
Yeah.
absolutely.
Yeah.
Not just.
Hmm.
Guilty. Um, I started practice, I was 24 years old. And I didn't have the self-confidence
Mm.
about presenting stuff.
Yep.
Fortunately, I had my the owner of the practice decided he wanted to be a mentor to me, and really, really helped me. Really helped me overcome that, I guess, lack of confidence.
It's amazing the difference between that age group and 48 and up. Takes 24 years or so. And I'm just averaging. I just had a client call a couple hours ago where we're looking at numbers, KPIs, and I've been meeting with the associate. And every time I meet with the associate, he says, yeah, case acceptance is great here, because he's in a different location where it's like Medicaid, let's say, and it's harder there. Here, the patients are they're so willing to move forward and all this kind of stuff. And the way he talks, you just think, oh my gosh, your numbers must be amazing. You look at numbers, and he's producing 2,100 a day. And I'm trying to show, and this practice is seeing 45 new patients a month for three doctors. Okay. So about 15 per. Well, senior doctor, who's producing about 4,100 a day, is only seeing 6 new patients a month. So not only are we giving all the new patients to the associate, but they're not turning that into a return. So not only is the associate producing too little per day, not getting patients healthy, but it's also putting the senior doctor at a disadvantage to get above 4,100 a day. He's almost hit the ceiling because, so we went through exam typing and how do you figure out what patients go to which dentist, because if we keep sending large cases to this associate and he thinks, oh, it's good, and he's doing this one crown a year club thing because approval addiction and this it's almost a lack of awareness, really. And when I meet with him, he goes, no, I'm good. I really like what you teach, and I feel confident in my presentation. And I'm like, how are you not seeing treatment plan? There's no treatment planning happening. I don't understand what's going on. There's this big gap, and I'm not a dentist. I can't go in and go, hey, let me look at your x-rays there. And the senior doctor doesn't want to ruffle feathers and lose an associate. So we went through a couple different tactics to solve that. But I mean, all I see is this very, very young dentist thinking everything's just right, and it's so not right. And when does that switch happen where all of a sudden he's going to go, oh my gosh, this whole time I have not been treatment planning that?
So that's a huge deal.
Yeah.
So, and I just made a presentation on case presentation,
Yeah.
but I think it was the wrong, I put the cart before the horse, because I think really it's a problem in diagnosing.
Treatment planning.
Well, diagnosing.
Yeah.
You diagnose, then you treatment
plan. Yeah.
And I think it's a failure of comprehensive diagnostics.
Yes. Or it could be, I see it, I'm going to put a watch on that. And because the approval addiction says I'm not actually going to diagnose an actual problem, it's like, is it or is it not? Are you pregnant or are you not pregnant?
So that's where I believe we've missed the boat in connecting the first 2 years of dental school to the last 2 years of dental school. So it was interesting to me because I taught many things while I was at Columbia, one of which was local anesthesia. So I taught it. My appointment was in the oral surgery department, and I taught it while the students were on their oral surgery rotation. We were teaching how to give injections. And I would quiz, these are third-year students who had anatomy in sort of the end of the first year, beginning of second year. So they're only a year out of anatomy. And I'm asking them, okay, we're going to give an injection. Describe the structures that needle is going through.
Yeah. Yeah.
Like no connection. Well, it's the same thing with diagnostics. So we teach, what are the risks of patients developing decay, gum disease, some kind of musculoskeletal traumatic stress related issue? What are the risks? And how do you manage those risks? And we talk about it. It's talked about in the second year. They call it preventive dentistry, whatever that is. You spend the next 2 years learning how to do things. Everything you learned is irrelevant. You have to learn how to do things. And then they get into practice and they don't get paid for the preventive part. They don't get paid for the diagnostic part. They can't get paid for the procedural part. So you want to know the etiology of all this pathology? That's what it is. There's no connection and there's no reward. So, and it's hard because in order to do what I laid out, the risk analysis for a patient to develop problems, we see the problems that they have. Had they develop, how can we prevent it from occurring again? To me, that's what we owe our patients.
And that takes time to sit there with the patient. And then it takes patient compliance to do the things that you tell them to do. And human beings would rather just pay some money to get out of a hole.
Right. So I used bacteria profiles. So I liked salivary diagnostics. So I would do salivary diagnostics. We would do bacteria profiles, pH analysis, buffering capacity. Insurance doesn't cover it.
I'm just going to say, yeah, but insurance. So you get that PPO practice listening right now going, I can't do that.
Well, right. So I have a conversation. Before I even present, I said, I'm going to tell you something that insurance is not going to cover. it's the way I would want to be treated, knowing what
Mhm.
I know and what I
Mhm.
see about with dental problems. And it's going to cost X number of dollars. So a couple $100 to figure out why you got to this point and how we can prevent that from occurring. I can
Again,
fix
yeah,
all these things.
yeah,
I can, fill the holes, I can fill the spaces, I can do all that stuff. But without the diagnostics that I'm talking about,
gonna keep happening.
I can't tell you how long it's going to last.
Hmm.
We've all seen crowns that we've done come back a couple of years later with recurrent caries.
Mm.
Why? What are the medications that they're taking doing to their saliva? I don't know.
Yeah,
So it's a
diagnostic and
but
prevention, and then how do you get paid for that? And that goes back to vision, back to ethics. It all circles around, and it's why you, the same patient goes to 4 different dentists, going to get 4 different treatment plans. No surprises there.
no,
So, what I would say for my own client problem is, you know, for now, I told him, look, you're the mentor here, senior doctor. You've got to meet with your associates regularly and review diagnosing, because he's not doing that. So he has no idea if things are being diagnosed or not. He's not really looking at the dentistry that's being diagnosed and treatment planned. I was like, they need to rely on you as a senior doctor. You're not stepping on toes. You're their mentor. And then secondly, it was, hey, we're also going to divvy up quality of new patient to who it should be going to here. So that's the start. We're going to see if it pays out or not.
so I'm going to give you a live update.
Yeah, you just got a live update on ethics.
So the selling doctor
Yeah.
confronted the buying doctor.
Mm-hmm. Is the purchase already through, by the way?
Yeah,
Okay.
done. Um, the buying doctor says, I was taught that
At the
at
last office.
the last corporate office I
Yeah.
was at.
Yeah. It's okay to do. Didn't know. Yeah.
Now the buying doctor's worried because the staff, who are now not his staff, has now lost trust and
Yeah.
confidence.
Yeah. Does the buying doctor realize now that it's a wrong thing and it was just ignorance? Yeah.
Now the buying doctor's worried
Yeah. The result of that was,
about his license.
yeah.
So I spent the weekend calling people to figure out what. So I'm a fellow of the American College of Dentists. So the American College of Dentists their thing is social responsibility and ethics.
Mm-hmm.
So I presented the scenario to someone at the college who's going to look into it. I
Mm-hmm.
also called one of my friends who's on the state board in Pennsylvania. So I teach at Temple, so I have a lot of connections in Pennsylvania.
Mm-hmm.
So she's on the state board and she happens to be an attorney as well. So we
Wow.
talked about it. Um, I I called the transition company who helped moderate this transfer, um, asking them to weigh in on what they. So now we know the etiology, though.
Yeah.
Ignorance.
Yeah. Ignorance, not necessarily corruption or
Right.
or
Right.
wanting to manipulate situations, just lack of knowledge. And that you can rebuild trust through that. You can just say, oh my gosh, I'm so glad you have my permission to always come to me and let me know. I don't claim to know everything. I'm learning from you like you're learning from me. Let's get there together, and no longer an ethical dilemma that displaced trust. Instead, it's a learning experience that can also be used to your advantage to say, see, we all don't know everything. And so when I'm coaching you, it's mutual.
So that brings us to leadership,
Mm-hmm.
right?
Yeah.
Part of leadership is admitting vulnerability, right?
Mm-hmm.
We don't have all the answers. We're going to have a pandemic and we don't know what to do, right?
Mm-hmm.
We're all going to travel this road together, and we're going to adapt as best as we know how with all the information that's rapidly coming in, rapidly evolving.
Think
Right?
about this. The person, and this is where people's own approval addiction. Think about that doctor buyer coming to admin team member, say, hey, I need to back bill this. And the admin team member just simply not saying, well, we can't do that, you know, in the right way. And just instead going, I'm approval addicted. I'm not going to talk to this doctor that way because I don't know them or what have you. And instead it festers and builds and creates this whole thing when literally it could have just been this simple conversation. If we have open communication channels, it could have been taken care of so much easier and saved you a lot of time too.
Well, so fortunately, I I spoke to the selling doctor early this morning,
Yeah.
and I said I'd sit down with the buying doctor and say, this is what I'm hearing, and then keep quiet.
Mm-hmm.
And so he did.
Mm-hmm.
And that's how this came out. Now you're right. Now there's an opportunity for buying doctor to step up, have a meeting, and say, listen, I'm a I apologize. I had no idea. And
Yep.
thankfully, selling doctor enlightened me. And now we're going to make amends.
Mm.
Do what's right. It's
Yep.
not an easy, not an easy thing
Hmm.
sometimes for doctors to do.
Yeah. Well, a good thing they have you in their corner to walk you through it.
Again, the value of a coach,
Yeah.
right?
Yeah. I'm thinking of two phrases that really go hand in hand. So vision alignment, and clarity of expectations. So vision alignment, how can I be in alignment with it if I don't know what it is? First of all, what's my vision? What am I trying to create? Who am I? What do I stand for? And if I saw something that was in conflict with what you said you stood for, I'd be more likely to be able to question it in this scenario. And then clarity of expectations. This happens when doctors will come to us and say, I got an employee going rogue, doing whatever she wants to do over here, doing this sort of thing. Okay, how often are you having your one-on-one meeting? What's the clarity of expectation? Like, oh, I don't do that. I just treat teeth. Okay, well, no fault of her own. She's out there doing what she thinks is right because she doesn't know what your vision is. There's no alignment to anything, and there's no clarity of expectation to be in alignment with. So those things have to be constantly reviewed. So every chance you get, you're going back to your vision, sharing a portion of that, and it's how you preface the meeting topic. It's how you preface the conversation you're going to have, because we're about total patient care and creating whatever it is. I want to talk about this expectation, and you get clear on it through conversation. It won't happen without communication. So ethics, even diagnosing and treatment planning, case acceptance, all of it circles around communication, your ability to dive in and do it effectively. So it's not easy. You can't just treat teeth.
No, we're treating people,
Yeah.
and sometimes we lose sight of that. Um,
Yeah. I say all the time, we're in the tooth industry, but we're in the relationship business. If you don't know how to manage relationships, team or patients, you're gonna be in trouble. You're gonna have these weird situations that come up that make you look like that's not at all what I meant.
and it's so I would add we're in the relationship and trust business,
Yeah. You can't be in a relationship without having trust. Yeah.
right? And if you're doing dental work that doesn't last, you're going to have a short-term relationship.
Mm, very.
Hmm.
Yeah. We Dr. Ted Morgan is, you know, great friend, presents with me. He's up in Maine, and he's amazing at the skills that we teach and train in his own practice and as a presenter. And he wrote an article for Dental Economics about trust, and he calls it the trust curve. And as you know, trust, vertical axis, relationship and time spent in this horizontal axis. And as you spend time in our relationship with people, what happens? Does trust go up or does trust go down? And what are those factors that we need to work on to tweak your ability in communication to improve trust, not decrease it? And not push, you're talking about case presentation, and not push people past what they're able to comprehend in the trust factor. It's like you come across as a pushy salesman because you don't have the trust and rapport to be able to get there. You're pushing too fast.
We should talk about that next month. We should talk about how to build trust.
All right.
I think that's really
build trust. It is. That will be our topic for June.
Yeah.
All right. Sound good?
That sounds great.
Awesome. Awesome. All right. Thank you everyone for joining us. I'll see some of you this week at our Growth Summit in Florida. And if you want more of that, Dr. Ted Morgan and I will be presenting in Maine, Portland, Maine, All-Star Dental Academy, our All-Star Mastery Series, October 19th and 20th. We'll do our level 1 there, which is on case acceptance. And I'm certain he'll be talking about building trust.
Cool.
All right. Thanks, Dr. Goldberg.
Well, you have a great trip.
Yes, you too.
Thank you.